Welcome to Voices for a Healthy Legacy, where we have discussions about health and wellness with relatable medical professionals. I am your host, Dr. Andrea, a board-certified family medicine physician, and today's guest is Dr. Kierstin Kennedy. Welcome to the show, Dr. Kennedy.
Thank you for having me.
All right, so I know your background in medicine is very comprehensive, so just kind of tell us a little bit about who you are and then like your education, because I know there are different layers to that.
Yeah, so I am dual trained in internal medicine and pediatrics.
Okay.
Clinically, I only practice internal medicine now, and I practice as a hospitalist, which is becoming more familiar to people. But for people that aren't aware, a hospitalist is someone who takes care of you when you get admitted to the hospital and then sort of releases you back to your primary care doctor after you get discharged. And so that is what I do in my clinical practice. Outside of my clinical work, I'm fellowship trained in quality improvement. I also have a master's in health administration, and my passion is really around improving outcomes in healthcare and in improving our processes, like how we take care of patients. And so to that end, I now function as the Chief Medical Officer for UAB Hospital.
Okay. And that's part of what I try to do, bring professionals on like you, because we want to improve those generational health outcomes. Yeah. People sometimes just, think about the here and the now, but what you do now for yourself influences your kids, your siblings, cousins, co-workers, just everybody. So even though we talk a lot about building a healthy family legacy, but really your family can be, church.
Oh yeah.
It can be college, friends, it could be so many different things. Yeah. So you are perfect for this. So what inspired you to go into internal medicine? So you're dually trained in internal medicine and pediatrics. So how did you arrive there? Like, were you a little girl that wanted to be a doctor? Kind of tell us how you got here.
I was. So my mom will tell you that I was saying I wanted to be a doctor probably back when I was like 7. And I will tell you that I didn't know what I was talking about. I think I was probably just saying it because it sounded good. I did not know what that meant. It's interesting because it wasn't until I met my uncle. I was 14. And I say met. He knew me from when I was a baby. I was born in Los Angeles. But
I didn't know that.
Yeah, but my dad was in the Air Force, and so we ultimately ended up going to Montgomery because Maxwell Air Force is there. So I don't remember, or Air Force Base, excuse me. I don't remember that uncle. I was too little, right? But he remembered me. But we had a family reunion when I was 14, and I feel like I was meeting him for the first time, and he was a doctor, and he was literally the first Black doctor I had ever seen, not on TV.
Really?
My pediatrician, was a white male. My dentist, I had never seen a Black doctor. And I vividly remember being like, wow, I know I've been saying it, but this might actually be doable. And he would tell me how he remembers me saying, I could be a doctor too. I'm really smart. And he said, yes, you can. And so it's so funny. I'm going to date myself because from there we started writing each other. I would write him letters and he would write me back and he would give me advice and he'd send me a little money.
Of course. Now that was always a good thing.
Oh, yes. So he was really my inspiration for, and to boot, 2 of his daughters were doctors. One had just finished residency and one was about to go into residency at that time.
Okay.
And so I was like, wow, this is a thing. I can really do this. And so from there, it was just college and on. It was like, what do I need to do to become a doctor? What's the next checkbox I need to check to become a doctor? And so then when I got into medical school, I do really like being hands-on and I like procedures, and I thought I might have wanted to be a surgeon. And then I steered away from that. It's interesting because in my practice now, I do still do procedures. I'm a proceduralist in the hospital. But I'm not a surgeon. I chose internal medicine and pediatrics because I love babies. I love kids. But I really love the complexity of internal medicine. And so I was like, wow, this way I could do both. I could treat anybody who walks in the door. I could do it all. I could see it all. So.
Okay. Now you said you're a proceduralist. So what are some procedures that you do as a hospitalist?
So we do ultrasound guided bedside procedures. So we I created the service back in 2014 with the intent to prevent having to take patients down to radiology to get procedures done that we felt like we could safely do at the bedside. So paracentesis, which is removing excess fluid from the abdominal cavity, which is something we see in patients that have liver disease most frequently. Thoracentesis, we can go right between the ribs and we can take that excess fluid off. We can do it right there at the bedside, make it super comfortable. It's my favorite procedure.
Really?
I always tell patients, like, and I have patients that will fall asleep while I do it.
Now that means you're not only, that's your favorite, and you must be really good at it, and you make them feel comfortable, because I've seen that procedure before, and it's not terrible.
No.
But for them to be that comfortable, that says a lot.
Yeah. And I will always, because at the time when I started the service, I was the only woman. All the rest of my colleagues that were willing to take that leap with me were all men.
Mm-hmm.
But I would, for patients that come in often and have to get it done over and over again, I'd say, when you get one of the other doctors, you just tell them, Dr. Kennedy, did the best thoracentesis you've ever had. We also do ultrasound guided lumbar punctures. So kind of like for those who aren't familiar, I know you know, but like when you get an epidural, when you have a baby, like instead of putting medicine in, you go between the vertebrae to be able to take fluid out. And we use that for analysis or to relieve pressure in certain patient populations. And then the last big procedure that we do is central line placements.
Okay.
So putting those catheters into the neck or into the groin or just under the clavicle here for dialysis or for medication administration, that sort of thing. We just recently started doing bone marrow biopsies as well.
So how do the patients respond to you doing it bedside? Are they more willing to have the procedure done, or they seem a little more at ease because you've probably been seeing them during their stay, or do you come in as a part of like their main internal medicine team during that time?
So we come in as consultants.
Okay.
Any service in the hospital can consult us to come and do it. And so oftentimes it's my first time meeting the patient and I may never see him again. And so that's sort of the art of being a hospitalist too, is that you meet these patients and they feel terrible. It may be the scariest day of their life. They don't know you and they may never see you again. And so it's really about like, how quickly can I build rapport? How quickly can I build that trust and make them feel comfortable? And so that's what we do. We come in and we love on them and we take care of them and we get the procedure done. We make them laugh, we make it comfortable and we get it done and then we leave.
Like you're in and out. You're like, you come in, you do your good deed and then you're off to the next one.
And then we're out.
So how did you decide to do hospital medicine versus outpatient? And I'm the opposite. Like I have done outpatient and I do not want to go into the hospital, which which is fine too. But how did you know that you did not want to do outpatient?
Like at one point I thought I wanted to be a surgeon. Like I liked doing procedures. I liked being hands-on. At the time, I really liked the acuity of inpatient medicine. Like these patients are really sick. Like they really need you. I liked the excitement of, running to codes and doing things like that. And so, it was clear for me then that I wanted to do inpatient medicine. I will say, now that I've been doing inpatient medicine for over a decade, we won't say exactly how far over a decade, but
that's okay. Well, over a decade works.
Now that I've been doing it for a long time, there is a part of me that starts to wonder if the next step might be outside of medicine. And not because I don't enjoy inpatient medicine, but it makes me sad. Like I see so many patients with illnesses that they don't have to have, I hate to use the term self-inflicted because I know no one's intentionally trying to make themselves sick, but it's stuff that we are doing to ourselves unknowingly or sometimes knowingly that ends up in the hospital. And I think the older I get and the more you look at a patient list and everybody's kind of close to your age, it just feels a little different. And so there are often patients where I think, if I could have gotten to you 5 years ago, like if we could have talked, 10 years ago, you might not have a medication list as long as you have, or you know what I mean?
Right.
So yeah. So that is where I'm so thankful for people like you out in the outpatient space, hopefully keeping people from ending up in the hospital.
Right. So speaking of, you were mentioning patients coming in with all these medical problems and so many different medicines. Do you ever notice that when patients come in, because I know I see this sometimes, they try to impress me and say things that they've tried to do, or, oh, I just have no idea why such and such. Do you see that in the hospital? And if so, can you talk a little bit about why that's not a good thing? I mean, I know, but I want them to hear it from the hospitalist.
No, I see it all the time. And it really it slows us down, and it's really risky, honestly. Like it's dangerous. A great example is, we have to ask about drug use, right? And we are not, and I will often say, I'm not asking because I'm judging. I'm literally only asking because there are common medications that we give in the inpatient setting that we don't want to give you if you have something else in your system. Oftentimes, if I explain it in that way, people might tell me, but there are still situations where they'll say, no, I don't, and then we get the urine and we can tell that it's in there. But that's why we always check the urine, because unfortunately, some people just will never feel comfortable enough to be honest with you. But yeah, I mean, that it's a great example. Like if you come to the hospital with chest pain, there are some medications that are standard for us to give if someone has chest pain that you would not want to give a patient if they have used cocaine, right? Like it can cause you to get so much sicker,
right?
Like potentially die,
right? It can be fatal.
Yes, and so that's, and I try my best to make patients feel comfortable, to be transparent, to tell them I'm not doing it to judge, but like we really need to be honest, so that we can get you better.
Right. And I try to tell them that too. Like, we're not here to judge. Like, you're here because hopefully you feel like you're in a safe space where you are surrounded by people who want you to feel better.
Right.
Not just now, but going forward. And I think that's one of the good things about the continuity of care, in outpatient, is that over time, patients, not all of them, but a lot of them will start being honest to the point where you're like, okay, you're telling me about everything in your family now. I don't know if they want me to know. I don't know if they want me to know that. They may be my patient, but okay, I'll take it, So, I just, I see it in the outpatient, and when I was a resident, going through hospital medicine, it's like, okay, it's not just outpatient people. And I think they don't want to appear bad, quote unquote bad, but things happen, and like you said, we're not here to judge, we're here to help. So when they do transition from hospital to outpatient, is there any type of connection that the hospitalist tries to make with their primary care physician? I know there are discharge summaries or things like that. Can you just talk a little bit about that? Because some patients, when they are discharged, they feel like, oh, well, the hospital doctor told me such and such, so I need to see what they say, so a lot of them don't understand your role is to take care of them, when they're acutely ill,
right?
And then they transition back to us.
Yeah, and that's probably where we have an opportunity to do a better job of explaining that to patients. So certainly any patient that has a doctor within the UAB system, we have a way to copy them on the discharge summary, and even to send them a message, kind of like an internal portal message, to say, hey, I'm discharging your patient. I've asked them to come back and see you on this day because we need to be looking for X, Y, and Z. I wish we did a better job at that everywhere, because it might make patients feel a little more comfortable going home. One of the things that we struggle with is, the intent of being in the inpatient space is to really take care of the things that are life-threatening. We don't always get to the final diagnosis. Sometimes what we're doing is we're ruling out all of the really serious things, the things that could cause you immediate harm, the things that could kill you, for lack of a better way to put it. But the work continues. Once we've ruled all that stuff out, and you no longer need, your vitals checked every 4 hours and a nurse coming in every few hours. Once you no longer need that level of intensive care, you should go home and you should continue this work with your primary care doctor. And I do wonder if we could bridge better, if patients would feel more comfortable leaving the hospital knowing that they're going to continue the workup with their PCP.
Right.
But it's hard, right? So, as a hospitalist, we work 24/7. We don't close. And so if I'm discharging a patient on Sunday, I can't necessarily call their primary care doctor,
right.
And for clinics that are outside of our system, I don't have, an email address for those doctors or a portal way to communicate. And so you do the best that you can. We can have it set up where it will send a copy of the discharge summary, but that's not coming over until Monday morning.
So many times when patients come into the hospital, they are super afraid. It's a very scary time for them. So what are some things that you can share with our audience about some things they can do to maybe ease their mind or just kind of a different perspective of looking at their hospital stay?
Yeah, so I think if I try to imagine where that fear comes from, it is not knowing what's going to happen next, not knowing how bad things are. And so I usually will encourage my patients to take notes. That doesn't bother me at all if they're taking notes. We're saying a lot of information at once. And so sometimes it may be hard to capture all of that. I also encourage them to, when I'm not in the room, it never fails. As soon as I leave out, before I leave the room, I ask, what questions do you have? I'll say, ask me whatever. And they might think of a couple of questions, and then I say, okay, well, I'll check in on you later. Right. I'll see you in the morning. And as soon as I get down the hall, they'll think of 8 different questions. Right? And I'm like, write those questions down. You don't have to feel like some urgency around it. Write those questions down. And then when I come in the morning, we will sit and go through every one of them. We will answer every one of those questions. And so I wish more patients felt empowered to do that. To as you're sitting in the bed and you're worrying and your mind is going 1,000,000 miles per hour, get that out of your head and onto paper.
Right.
So that you know exactly what it is you're concerned about. And a lot of it is, well, if I know you're doing this test, what if it shows this? What happens? Or what,
Right.
Put all that on paper. And then let's sit and let's walk through it. And I think patients would walk away feeling a little more reassured and more informed about what's going on with them.
Yeah, because it can be a lot. There are a lot of people in and out. They're getting their blood drawn. They may get different types of imaging done. They may have different specialists coming in and out. So it's a lot of information. So that's really good for them to just simply write it down. And I don't know if you see this too, the patient may not have questions, but their family members or friends may have questions. So do you encourage them to write those questions down? So, and maybe have them, that brings me to another question. So a lot of people, while I'm thinking about it, let me ask this. So a lot of people are like, it takes the doctor forever to come around. We've been waiting since blah, 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 blah. And for them, they want their answers quickly. So tell me, what does a typical day look like for a hospitalist so that people will have a better idea of if you don't come at 6 or 7 in the morning, kind of what's going on, because they don't know. They just feel like they're just taking too long,
Listen, thank you for asking this. Okay. I am so glad you asked this question. That is the hardest thing for me, is when I walk into a room, and I've learned as I've grown and matured, I've learned not to react to it. But you walk into a room and they go, finally, the doctor's here. Listen, I'm going to call you back. And they go, we've been waiting on you. And I just want to feel like I'm running as fast as I can. So I typically will start my day as a hospitalist somewhere between 6 and 7 a.m., in the hospital, right? Before I can go out and round, I have to fully understand what's happening with the patient. And I have to already have some semblance of a plan, right? Now, that plan could change a little bit based on what I find when I go into the room, as far as things that they might tell me in history or things I might find on physical exam. But I have to go through everything. I go through Notes from the night before, if they were already in the hospital, were there any cross-cover notes? Did they call out overnight about an issue? If so, typically that's documented. I want to see what that was. I'm looking at every medication that they got yesterday. I'm looking at every imaging study that they got yesterday and reading over all of the reports. I'm looking at every lab that was drawn, and then I'm piecing all of that together. I'm looking through the nursing notes. Did they refuse a medication? Did they refuse to be turned? Did they have an issue overnight? Like, it's pulling all of that data together and then being like, okay, this is what the labs are showing. I see this on this x-ray. What do I need to potentially do next? We called a consultant yesterday. What did they say? What are they wanting me to order today? And so putting all of that together and doing that for 18 different patients oftentimes, right? And if it's a brand new patient, I'm not just going to look at what happened last night. I'm going to look at the H&P, like the history and physical that they did when you first showed up in the ER. I'm going to look at the ER doctor's notes. If you're in our system, I'm going to look at prior clinic notes.
Right.
As I'm looking at your blood pressure here, let me look at your clinic note from 6 months ago and see what your blood pressure looked like then. Is this the same? Is this something different? Like a heart rate? There's so much that you have to look at before you can walk out and go into the patient's room. What would be worse is if I immediately show up at a patient's room at 6:30 a.m., which I can do, and be like, well, I don't know. I don't know anything about it. I don't know what we're going to do today. You know? Oh, right. Something happened last night. I didn't see that.
Right. You know? Right. Which is not the standard of the care that you give on any level.
No, and that's not what the patient wants.
Right.
What the patient typically experiences is that the doctor comes in and somehow this doctor knows all about you. They know all about what brought you here. They already have a plan. We're going to change this medicine. We're going to do this. Like, that comes from all of that review of data and preparation before walking into the room.
Right.
And so you got to give the doctor time to do that. And I think also, you know, maybe it's a good and a bad thing. Like, I work really hard to make a patient feel like they're my only patient, because they only need to be worried about themselves. It's not their job to worry about the other patients on my list.
You were mentioning that you like patients to feel like they're the only patient, even if they're not, because you want to give that good care for them. So kind of talk a little bit about your, like you kind of, how do you, I don't want to say prioritize, because everybody is important. If they're in the hospital, they're sick enough to, you know, get that intense care. So how do you decide, like, who gets first? Because some patients want to be seen first thing in the morning, but it may be first thing in the afternoon. So how do you kind of decide who gets seen at what time?
Yeah, that's a great question. So the first patient that I'm going to see is the patient that is the sickest, right? So if that patient, I'm not taking care of patients in the ICU. My goal is to get patients home. So if I have a patient that's going in the opposite direction, they're looking sicker and sicker. The nurses call me, I'm really worried about them, or I can't get them to wake up, or, you know, like, I want to go see them first, because I don't want them getting sick to the point where they go to the ICU. We're supposed to be going this way.
Right.
So I've got to see that patient first. Certainly if they call a MET, which is like our emergency response team, like if they call that, like, that means everybody drop what you're doing and come get to this patient now. Let's see how we can help this patient. Or a code, which is even more serious, where a patient's heart is stopped or something like that. Those patients have to be seen first. And then the next round of patients that I try to see are the patients that are going home, right? Because I want to make that an efficient process for them. So I try to do as much, again, in advance before I see them, while I'm going through their chart and I'm confirming, yes, that blood pressure looks better. And yes, those labs look good. Yes, we are ready to go home. I'm going to go ahead and start putting in all of the D part paperwork that has to be done, so that after I see them and I confirm that they look as good as their numbers do, all I have to do is walk out of the room and hit the discharge order. Gotcha. Everything else is done. Because there's a lot of paperwork, but like, it's more than just hitting discharge. There's stuff that the law requires you to fill out in preparation for the patient going home, to show that, yes, this episode of care is ready to end.
Right.
So I try to do that in advance. And then I go and see the other patients that are not ready to go home, but also not sick enough that they're getting ready to go to the ICU either. And then I just try to run through those patients as quickly as I can. And again, when I go into each room, I want to spend as much time as that patient needs. Remember, I tell my patients, write down all your questions. We will sit and go through them, and that will take as much time as it takes. Mm-hmm. But that sometimes delays going to see the next patient.
Right.
But what I also try to remind them is that you're going to get that same thing. When I come in your room, I want to see your list, and I'm not going to rush you through your list either. Just like I didn't rush them through theirs. We're going to sit and go through everything. So, yeah.
Hopefully that kind of gives patients a better idea of what's going on. Because, a lot of times I think that part of the unknown outside of what's going on with their medical problem, they're like, well, where's the doctor? What are they doing? Like, this is their job, you know, and it's like to do it well. Sometimes, you may get seen a little bit later. Mm-hmm. And in this case, sometimes if you're getting seen a little bit later, that might be a good thing because you may not be the sickest and you may be closer to going home.
That's right. And in fairness, I mean, it is nerve-wracking to be sitting there and not knowing when, and especially now, we're in a culture where we have everything ready access at our fingertips. Everything is instant. And so it is difficult to not know, like, I hear people walking outside. Is that my doctor? Is the next not going to be my doctor? So I get that. And so, like I said, when I show up and patients say, oh, we've been waiting for you all morning, I just apologize. I just tell them I'm sorry.
Yeah. Because if you could get there, a little more quickly, you definitely would. But sometimes, depending on what the day looks like, you may not. All right. So I don't know if I would say recently, but now you are the chief medical officer of UAB. In addition to being a hospitalist, proceduralist, mom, wife, all the things. So how did you transition into that role, and how has that changed what your day-to-day life kind of looks like?
So I have always done a mix, and just over time, I've gravitated to more and more of the administrative work because someone has to help design the system. Right. Someone has to solve problems. Someone has to identify where there are kinks in the road and try to smooth those things out so that we can deliver good care. And so 3 years ago, I moved into the chief medical officer role. And that is a, primarily administrative role. I am, looking at our systems, sitting with groups and figuring out, like, how can we improve it? How can we make it better? Where do we have issues? Where are we not resourced like we need to be? Where do we just not have enough structure around what we do?
Right.
We need to create some structure. So I do that. And so what that means is that I don't see patients as often. So I only take care of patients every other month. So every other month I do a little stretch, usually over the weekend.
Okay.
Like a Friday through a Monday or Tuesday or something like that. And I come in and I take care of patients. Okay. And so that is the difference. But it's a nice balance because every time I go out and take care of patients, I get to feel like the changes that I'm making as chief medical officer, and I get to identify other opportunities too, to see sort of what's working, what's not working, and where we need to do better.
Right. That's kind of a good perspective because for the changes that you are asking for, people, you can say, well, I've done it myself. I've been able to see how this can improve or how we need to take this away, based on when I've been out there. Yeah. And because you're still having that touch point with the patient.
Well, and it's important from a leadership perspective as well, right? So, I don't want to tell these physicians to do something that I'm not willing to do.
Right.
So when I do ask them to make some sort of change, I can genuinely say, I'm going to feel it too. I'm going to be in there with you too. I'm not making these requests from up on high. Like we're both going to have to do better.
Right.
In this way. We're both going to have to add this extra step if that's what it requires,
So, Dr. Kennedy, you've accomplished so many things, and you're still very young. So, and most people
that again. Okay, sorry, go ahead.
And you're very young, but you are. Because a lot of people think, the accomplishments that you've been able to get up until this point, you have to be like near retirement to be able to get it. So, what is your advice for some of the young girls or young women who may look at you and say, wow, she's done so many wonderful things? How do you encourage them to stay focused and motivated towards meeting their goals, even if you have some examples of things that have helped you along the way?
Yeah, so it's an interesting question. I don't know exactly how to keep people motivated. I think that motivation has to be internal. I can speak to what has kept me motivated. But I will say this, I right now have had some opportunities to go back and look at what I've done over the years, and you see all of these accomplishments, and it looks so, massive, and it looks impressive, but that is just an amalgamation of little bitty steps. Like, I just do little things. Like, every day I get up and I try to be a little bit better, or, I try to make good choices. That's what I tell my children.
Me too. I tell my son that.
Well, because, honestly, like, we are one bad choice from losing everything. And so that's what I try to remind my children. So every day, my goal is not to amass this huge resume or, this huge list of accomplishments. Every day, my goal is to make a good choice today. And over time, that piles up. And you will look back and you will see what day after day after day of good choices looks like. And that is kind of how you get there. I think for me, because I've had these little goals, little things that I'm working toward, little things that are important to me, one of the biggest components has been staying honest with myself and keeping my word to myself. And I think if you don't keep your word to yourself, you won't be able to accomplish those things. You won't be able, and you can't get other people to I'm not going to trust anybody who doesn't keep their own word to themselves. Like, you should love you more than you got to look at you every day.
Right.
You don't have to look at me every day.
Right.
If you can't keep your word to yourself, you definitely can't keep it with me. So I keep my word to myself. If I tell myself I'm going to do something, then there are no excuses. I said I was going to do it. That was my commitment to myself. And first and foremost, I keep my word to myself so that people can trust that I will keep my word to them.
So you live it every day. The small, and I have even talked about this, small steps add up over time. And sometimes, I think people look for a magic formula, but it really can be that simple. Just the day-to-day living, the day-to-day choices, just to keep going.
Yeah. And that's true in health too. So like when I talk to patients and we talk about needing to make these lifestyle changes with the way that we eat, like, you don't need to try to go home and wipe everything out of your pantry and all of a sudden eat nothing but, fruit and nuts. Like, we can just start with little things. We can start with agreeing that we're not going to do canned vegetables anymore. We're going to do frozen vegetables so that we can cut out that excess sodium. We can agree that we're not going to do canned soups. That's too much sodium. We don't have time for that. We could be getting that in the form of salt that we can taste.
Right.
The good salt on food, right? And let's just start by making just one good choice. Like, and after you do that for a while, that becomes normal. I remember when I gave up sodas, which sounds so incredible now, it really was just that I'm just going to try to make sure I drink a certain amount of water each day before I can have a soda or before I can have sweet tea. And my thought process was, if I hit my goal for my water, then I can have that. And I don't need to feel guilty about it. Right. But if I don't hit my goal, I got to be honest with myself, right? I got to keep my word to myself. I'm not going to grab that Sprite or that Coke because I knew I hadn't hit my 64 ounces. And I was honest with myself about that. But then because I had done it for so long, one day I finally hit 64 ounces. And I said, oh, I'm going to grab a Coke. And that Coke was so sweet. I was like didn't even want to drink it.
Right.
And I realized now it's easy for me to reach for water. Like I've kind of, because of these little baby steps, I've gotten to a place where like that is normal for me and my body likes it. Oftentimes our body prefers that stuff.
Right.
It's the brain that is used to having that sugar rush or that, that feeling.
For sure. What advice would you leave with our audience about building a healthy family legacy?
I try to make good choices every day, and I teach my children that. Like, it's not about making these massive, like, monumental improvements. It's just about each day trying to make good choices. I work out every day. That's important for me. It's a part of me maintaining balance between work and home. It's important for me to be healthy. I feel like I have to set that example for my patients. I can't tell my patients to eat better and I don't do it. I can't tell my patients to work out and I don't do it. The first thing they're going to say is, I don't have time. Well, I need to be able to show them how I've figured out a way to make time. So it's things like that. Because my children see that,
any weekend, if I'm making up a workout on a Saturday, they come out there and they want to work out with me.
Oh!
And they design their own little workouts. Like last weekend, it was so cute. Like, or was it was a holiday. It was a weekday where they were out of school. But my 6-year-old said, you know, I'm going to do 10 of these and then I'm going to go for a run.
Oh!
I said, okay, well, get your workout, girl. But what we're doing is we're normalizing that this is what we do. Like, the body is made to move. We get up in the morning, we do a little workout, right? So, you know, doing things like that. And then I think just also having an awareness of what we're modeling. So I try to be really thoughtful about what I model as far as the way that I speak, you know, the things that I do, the way that I, you know, spend money, like the financial decisions that I make. Like, children see it all.
Right.
And that whole do as I say, not as I do, just, it does not work.
At all.
It doesn't work.
Right.
And so if you not, I guess my biggest thing, if you're not prepared to be better, don't expect your kids to be better.
That is so true. That could have been like the whole interview right there. Cut. So if people want to know more about the services that you offer, or just how to get in touch with you, I know you do a lot of things with leadership. Can you talk just briefly about that? And if people want to reach out to you about that, about speaking, how can they get in touch with you?
Yeah, I do a ton of leadership training. You know, that is another passion of mine, because I really believe that it requires, you know, education and a skill set that's not guaranteed to be there. And so, yeah, I do a lot of speaking on building strong teams, on emotional intelligence. I do a lot of speaking on quality improvement, how to leverage positive psychology to get people engaged, and on communication and conflict resolution. So if people, unfortunately, they cannot come see me clinically unless they are sick. So I don't want anybody reaching out trying to come see me clinically. It means you're getting admitted to the hospital.
Right.
But I also do some executive coaching. I've primarily worked with women in leadership positions, but, you know, I now have 2 clients that are men. And so, you know, anyone who's interested in growing themselves as leaders and in their own professional development and leadership, I'm always happy to coach and be alongside that. So I do have a website. It's Dr. Kierstin Cates.com. People can reach out to me there. Okay. And that's probably the easiest way to contact me. So, yeah.
All right. Well, thank you so much. And I'm sure you will be getting tons of phone calls. Or emails or what have you. So thank you so much for letting me spend some time with you today, even though I know your time can be very a little scarce at times.
Well, I'm glad to do it. I appreciate the invitation. This was fantastic.
Yes.
Thank you.
You're welcome. Thank you for tuning in to this episode of Voices for a Healthy Legacy. We will see you next time.